Assalamu alaikum. Today's topic in the series of online lectures is malaria, and my name is Muhammad Awais, one of the assistant professor in Paediatrics. Introduction. So you are all familiar with the malaria. Malaria is an acute and chronic illness characterized by intermittent fever, rigors and chills, sweats, fatigue, anemia, and splenomegaly. And most malarial deaths occur among young infants and young children. Etiology. Malaria is caused by intracellular Plasmodium protozoa transmitted to humans by female Anopheles mosquito. So this is the causative agent, Plasmodium, and which is the protozoa, and Anopheles mosquito is the vector. So malaria also can be transmitted through blood transfusion, use of contaminated needles, and from a pregnant woman to her fetus. This is the geographical presentation, geographical distribution of the malaria endemic areas in which the malaria is more common. So this is the life cycle of Plasmodium, and as you can see in the diagram, the mosquito, infected mosquito bites a healthy person and injects sporozoites inside the body of the healthy human. And there are two cycles, exoerythrocytic and erythrocytic cycle inside the human body. In exoerythrocytic cycle, primarily the sporozoites enter the liver cells and they form a structure called schizone, and which release lot of trophocytes inside the bloodstream, and these trophocytes enter in the red blood cell. A few of them again make the schizone, but few of them will make the gametocytes. Schizone will rupture the RBCs and the rigors and chill symptoms will occur in the patient, while gametocytes are taken up by the mosquito, and in the gut of mosquito the microgamete enters in the macrogamete and forms zygote, which is called ookinete, and then it becomes oocyst, which is released in the saliva of mosquito when it bites to the healthy person again. So four important pathologic processes have been identified in patients with malaria, which are fever, anemia, and immunopathological events and tissue anoxia. Fever occurs when erythrocytes rupture and release merozoites into the circulation. Anemia occurs due to hemolysis, sequestration of erythrocytes in spleen and other organs, and bone marrow suppression. And immunopathological events that have been documented in patients with malaria include excessive production of pro-inflammatory cytokines. Cytoadherence of infected erythrocytes to vascular endothelium occurs in falciparum, and that's why it can lead to the obstruction of blood flow and capillary damage, resultant vascular leakage of blood, protein, and fluid, and tissue anoxia. That's why falciparum malaria can be lethal in some conditions. In addition, hypoglycemia and lactic acidemia are caused by anaerobic metabolism of glucose. The cumulative effects of these pathologic processes may lead to cerebral, cardiac, pulmonary, intestinal, renal, and hepatic failure, so multi-organ failure. So coming to the clinical manifestations, and as in all infections, there is usual incubation period, which is different in different species of Plasmodium. For example, 9 to 14 days for P. falciparum, 18 to 40 days for P. malaria. The incubation period can be as long as 6 to 12 months for P. vivax. It can also be prolonged for patients with partial immunity or incomplete chemoprophylaxis. A prodrome lasting for 2 to 3 days is noted in some patients before parasites are detected in blood. Prodromal symptoms include headache, fatigue, anorexia, myalgia, slight fever, and pain in the chest, abdomen, and joints. The classical presentation of malaria consists of paroxysmal fever, alternate periods of fatigue, but otherwise relative wellness. Febrile paroxysms are characterized by high fever, sweats, headache, as well as myalgia, back pain, abdominal pain, nausea, vomiting, diarrhea, pallor, and jaundice. Paroxysms coincide with the rupture of schizones, which I have already discussed, and periodicity is less apparent with falciparum than others. Children with malaria often lack typical paroxysm and have non-specific symptoms including fever, which may be low grade but is often greater than 1 or 4 degree Fahrenheit. Headache, drowsiness, anorexia, nausea, vomiting, diarrhea, and distinctive physical findings on examination are splenomegaly, but you can find also hepatomegaly and pallor. Falciparum is the most severe form of malaria and associated with higher density parasitemia and number of complications like severe anemia, and there can be cerebral malaria, acute renal failure, respiratory distress from metabolic acidosis, Algid malaria, which is also severe malaria, and bleeding diathesis. The diagnosis of Plasmodium falciparum malaria is in a non-immune individual constitutes a medical emergency. Severe complications and death can occur if inappropriate therapy is not instituted properly in a non-immune individual. So WHO criteria for severe malaria is impaired consciousness, prostration, respiratory distress, multiple seizures, jaundice, hemoglobinuria, abnormal bleeding, severe anemia, circulatory collapse, and pulmonary edema. Congenital malaria. As per name, congenital malaria is acquired from the mother prenatally or perinatally and a serious problem in tropical areas. In endemic areas, congenital malaria is an important cause of abortions, miscarriages, stillbirths, premature births, IUGR, intrauterine growth restrictions, and neonatal deaths. Diagnosis. The diagnosis of malaria is established by identification of organisms on ginger-stained smears of peripheral blood or by rapid chromatographic assay. Like both thick and thin smears should be examined. Along with thick and thin smear, the binoxidil malarial test is approved by the US FDA, and for rapid diagnosis of malaria. PCR is even more sensitive than microscopy, but is technically more complex. Differential diagnosis of malaria includes viral infections such as influenza, hepatitis, dengue fever, sepsis, pneumonia, meningitis, encephalitis, and a long list. Treatment. General recommendations for pharmacological treatment of malaria are as follows. Falciparum malaria, quinine-based therapies with quinine or quinidine sulfate plus doxycycline or clindamycin or pyrimethamine sulfadoxine combination. Alternative therapies are artemether, lumefantrine, atovaquone, proguanil, or mefloquine. Falciparum malaria, in which areas where there is chloroquine susceptibility, we use chloroquine as well, but in area where there is resistance to chloroquine, we use alternative like artemether, lumefantrine, for example. PY-Wakes, PO whale malaria, we use chloroquine plus primaquine. In Plasmodium malaria, we use chloroquine. In Knowlesi malaria, which is a newer species of Plasmodium, same recommendation as for Plasmodium falciparum malaria. What is cerebral malaria? Cerebral malaria is defined as the presence of coma in a child with falciparum parasitemia and an absence of other reasons for coma. Repeated seizures and hypoglycemia is common. Physical findings may be normal or may include high fever, seizures, muscular twitching, rhythmic movement of the head or extremities, contracted or unequal pupils, retinal hemorrhages, hemiplegia, absent or exaggerated deep tendon reflexes, and positive Babinski sign. Lumbar puncture reveals increased pressure and cerebrospinal fluid protein with nucleocytosis, normal glucose, normal protein. Treatment of cerebral malaria other than antimalarial medication is largely supportive and includes evaluation and treatment of seizures and hypoglycemia. Although increased intracranial pressure has been documented in some children with cerebral malaria, treatment with mannitol and corticosteroid has not proved an outcome of these children. What is Algid malaria? Algid malaria or circulatory collapse is a rare complication that manifests as hypotension, hypothermia, rapid weak pulse, shallow breathing, pallor, and vascular collapse. Death may occur within hours. Severe malaria is occasionally impaired by bacteremia, which may have been the cause of some of the cases previously referred to as Algid malaria. What is tropical splenomegaly syndrome? Tropical splenomegaly syndrome is a chronic complication of falciparum malaria in which massive splenomegaly persists after treatment of acute infection. The syndrome is characterized by marked splenomegaly, hepatomegaly, anemia, and elevated IgM level. Prolonged antimalarial prophylaxis for at least several years is required to treat the syndrome if the child remains in a malaria endemic area. Spleen size gradually regresses on antimalarial prophylaxis, but often increases again if prophylaxis is stopped. How we prevent malaria? Malaria prevention consists of reducing exposure to infected mosquitoes. Number one, and number two, chemoprophylaxis. How we will reduce the exposure, and how we'll do the chemoprophylaxis we'll discuss. So reducing exposure. Travelers to endemic areas should remain in well-screened areas from dusk to dawn when the risk of transmission is highest. They should sleep during they should sleep under permethrin treated mosquito netting and spray insecticide indoors at sundown. During the day, the travelers should wear clothing and covers the arm and legs with trousers tucked into shoes or boots. Mosquito repellent should be applied to thin clothing and exposed areas of skin with application repeated every 1 to 2 hours. A child should not be taken outside from dusk to dawn, but if her risk for exposure is there, a solution with 25 to 35% DEET should be applied to the exposed area except for the eyes, mouth or hands. Hands are excluded because they are often placed in the mouth. Chemoprophylaxis is necessary for all visitors to and residents of tropics who have not lived there since infancy, including children of all ages. Healthcare providers should consult the latest information on resistant patterns before prescribing prophylaxis for their patients. Chloroquine is given in the few remaining areas of the world free from chloroquine-resistant malaria strains. In areas where chloroquine resistance, we give atoquine, proguanil, mefloquine, or doxycycline, and chemoprophylaxis. This is the table which I have already discussed. Thank you very much. If you have any question, you can ask in the YouTube section of the lecture. Thank you.